Welcome to our podcast on An Introduction to Anesthesia. We're going to be taking you through the main stages of what a patient goes through when they have an anaesthetic. I think it's important that medical students and young doctors understand what happens when a patient undergoes surgery that needs anaesthesia. Anaesthesia is a drug-induced, reversible loss of consciousness. And traditionally we think of it as having three parts: hypnosis, which is the unconsciousness element; analgesia, which is the pain relief element, which can be systemic analgesia or regional, local analgesia; and neuromuscular relaxation or paralysis. Of course, each of these things has specific and different side effects, and that's one of the skills of the anaesthetist, to balance and treat these side effects. In the preoperative assessment unit, the patients meet a nurse or a doctor. Here, they have a history taken, they're examined, and appropriate investigations are performed. We always discuss with them the risk of surgery, the risk of anaesthesia, and any alternative treatments. We also encourage them to become involved, fully involved, and aware of what treatment options may be available to them, including not having surgery, which is called shared decision making. We also offer any suggestions as to what modifiable risk factors they may have, for example, losing weight, exercise, smoking, or continuing, stopping, or starting new drugs. One of the basic divisions of anaesthesia is between general or regional anaesthesia. The typical anaesthetic that we think of an anaesthetic is a general anaesthetic. The patient's unconscious. But with a regional anaesthetic, which we can do in addition to a general anaesthetic, the patient need not be fully asleep. They can be sedated or even awake. The regional anaesthetic is great at reducing postoperative pain, but of course there may be specific side effects. For example, as nerves travel together, motor and sensory nerves, it may be that we will reduce the walking or the motor function of the patient in the immediate postoperative phase. Okay, so the patient has come to the day of surgery. They've arrived at the hospital and they've come to the anaesthetic room, which is what we see here. We've got pictured here a big stack of airway equipment, a skilled assistant, monitors, and the anaesthesia machine, which is the way of delivering a very controlled, precise amount of gas to the patient. Before anaesthesia or surgery can start, we have to do the WHO surgical safety checklist. This is a checklist designed to reduce wrong site surgery, encourage communication between all the members, including the patient, and to make sure there are no preventable errors that are about to take place. Once the WHO checklist has been done, we can move to the immediate phases of anaesthesia around the time of surgery: induction, maintenance, emergence and recovery. Induction involves going to sleep, maintenance of course staying asleep, emergence moving from that surgical state of sleepiness through to awakeness, and then recovery, getting back all your normal vital signs, including eating and drinking, speaking, your ability to control your own airway. At each stage of the process we can think about it in terms of an ABCDE approach. What are we going to do about the airway, the breathing, the circulation, the drugs, and the environment of the patient, for example, temperature, skin and eye care? Induction of anaesthesia can be done two basic ways. We can do it in terms of a standard intravenous induction, which is probably the most common way, certainly in the UK. We give an intravenous analgesic agent, usually fentanyl, which is a short-acting opioid, and then we give propofol, which is a hypnotic agent. We can also induce anaesthesia in a volatile or inhalational way. Here we'll give the patient oxygen and air, or oxygen and nitrous oxide, with sevoflurane. When we're thinking about a general anaesthetic, as I said, we think about the triad of anaesthetic drugs: hypnosis, analgesia and neuromuscular relaxation. We give neuromuscular relaxation if intubation is required or if the surgery needs a still patient. This can be either a depolarizing, succinylmethonium, or a non-depolarizing, also known as a competitive, such as atracurium, rocuronium or vecuronium. The general anaesthetic agents and neuromuscular relaxation cause obtunding or loss of the airway. The solution to this is to provide an artificial airway device. Initially, though, we would do some airway manoeuvres, chin tilt, jaw thrust, and then we would add some adjuncts such as a Goodell airway or another supraglottic device such as a laryngeal mask airway. And we may even intubate the patient, that is, put a tube through the vocal cords into the trachea and blow up a cuffed oral endotracheal tube. We can maintain anaesthesia in one of two ways, in the same way as we can induce anaesthesia in two ways. We normally keep a patient unconscious with volatile drugs in oxygen and air, but we can continue an intravenous maintenance dose of propofol, usually with an intravenous opioid. Here we see a close-up of the anaesthetic machine, where the anaesthetist has dialed up some oxygen, some air, and some sevoflurane. There are several issues about the immediate perioperative care. Analgesia, or pain relief, reduces the sympathetic response, i.e. the heart rate rises, the blood pressure rises, and the respiratory rate rises.